What is abdominal aortic aneurysm and its causes, treatment and prevention? Welcome to Heal Plus. So before starting this video, make sure to hit that like button, subscribe to our channel to join our family. As found further, ultrasounds are typically done on a regular basis. Not smoking is the single best way to prevent a disease. Other methods of prevention include treating high blood pressure, treating high blood cholesterol, and not being overweight. Surgery is usually recommended when in triple_'s diameter grows to 5 centimeters, 5 cm in males, 0 cm in females. Other reasons for repair include the presence of symptoms, and the rapid increase in size. Repair may be either by open surgery or endovascular aneurysm repair. As compared to open surgery, AVANR has a lower risk of death in the short term and a shorter hospital stay, but may not always be an option. There does not appear to be a difference in longer-term outcomes between the two with the VI, or there is a higher need for repeat procedures. AAAs affect between 2 and 8% of males over the age of 65. Rates among women are a quarter as lower back or scrotum. The risk of rupture is high in the symptomatic aneurysm, which is therefore considered an indication for surgery. The complications include rupture, peripheral embolization, acute aortic occlusion, and aortic cavil or orientado. The ineffectually on physical examination of palpable and pulsatile abdominal mass can be noted. Bruits can be present in case of renal or visceral arterial stenosis. Aortic rupture. The signs and symptoms of a ruptured eye may include severe pain in the lower back, flank, abdomen, or groin. A mass that pulses with a heartbeat may also be found. The bleeding can lead to a hypovolemic shock with low blood pressure and a fast heart rate. This may lead to brief passing out. The mortality of triple rupture is as high as 90%. 65 to 75% of patients die before they arrive at the hospital, and up to 90% die before they reach the operating room. The bleeding can be retroperitoneal or into the abdominal cavity. Rupture can also create a connection between the aorta and intestine, or inferior vena cava. Flank ischemiosis is a sign of retroperitoneal bleeding, and is also called Great Turner's sign. Or particulars in rupture may be mistaken for the pain of kidney stones or muscle-related back pain. The exact causes of the degenerative process remain unclear. There are, however, some hypotheses and well-defined risk factors. Tobacco smoking. More than 90% of people who develop and have smoked at some point in their lives. Alcohol and hypertension. The inflammation caused by prolonged use of alcohol and hypertensive effects from abdominal edema, which leads to hemorrhoids. Esophageal versus and other conditions is also considered a long-term cause of triple A. Genetic influences. The influence of genetic factors is high. AAA is 4 to 6 times more common in male siblings of known patients, with a risk of 20–30%. The high familial prevalence rate is most notable in male individuals. There are many hypotheses about the exact genetic disorder that could cause higher incidence of among male members of the affected families. Some presume that the influence of alpha-1 antitrypsin deficiency could be crucial, while other experimental works favored the hypothesis of X linked to mutation, which would explain the lower incidence in heterozygous females. Other hypotheses of genetic causes have also been formulated. Connective tissue disorders such as Marfan syndrome and Ehlers-Danlos syndrome have also been strongly associated with triple A. Both relapsing polychondritis and pseudoxanthoma elasticum may cause abdominal aortic aneurysm atherosclerosis. The triple A was long considered to be caused by other road sclerosis because the walls frequently carry an atherosclerotic burden. However, this hypothesis cannot be used to explain the initial defect and the development of occlusion which is observed in the process. Other causes of the development include infection, trauma, arthritis, and cystic medial necrosis. The most striking histopathological changes of the charismatic gay are that are seen in the channel comedia and in the middle layers. These changes include the accumulation of lipids in phone cells, extracellular free cholesterol, crystals, calcifications, thrombosis, and ulcerations and ruptures of the layers. Adventitial inflammatory infiltrate is present. However, the degradation of the tunica media by means of a proteolytic process seems to be the basic pathophysiological mechanism of triple A development. Some researchers report increased expression and activity of matrix metalloproteinases in individuals with triple A. This leads to elimination of elastin from the media, rendering Va-Ordak while more susceptible to the influence of blood pressure. Other reports have suggested this urine protease granzyme B may contribute to aortic aneurysm rupture through the cleavage of DCA, or in leading to disrupted collagen organization and reduced tensile strength of the adventitia. There is also a reduced amount of a cervase or M in the abdominal aorta. Consequently, the tunica media must rely mostly on diffusion for nutrition, which makes it more susceptible to damage. Hemodynamics affect the development of AAA, which has a predilection for the infrarenal aorta. The histological structure and mechanical characteristics of the infrarenal aorta differ from those of the thoracic aorta. The diameter decreases from the root to the aortic bifurcation, and the wall of the infrarenal aorta that also contains a lesser proportion of elastin. The mechanical tension in the abdominal aortic wall is therefore higher than in the thoracic aortic wall. The elasticity and distance ability also decline with age, which can result in gradual delimitation of the segment. Higher intraluminal pressure in patients with arterial hypertension markedly contributes to the progression of the pathological process. Suitable hemodynamic conditions may be linked to specific intraluminal thrombus patterns along VI or DEC lumen, which in turn may affect trival_'s development. An abdominal aortic aneurysm is usually diagnosed by physical exam, ultrasound or CT. Plain abdominal radiographs may show the outline of an aneurysm when its walls are calcified. However, this is the case in less than half of all. In prisms, ultrasonography is used to screen for aneurysms and to determine the size of any present. Additionally, free peritoneal fluid can be detected. It is non-invasive and sensitive by the presence of Babel gas, or obesity may limit its usefulness. CT scan has a nearly 100% sensitivity for an aneurysm and is also useful in preoperative planning, detailing the anatomy and possibility for endovascular repair. In the case of suspected rupture, it can also reliably detect retroperitoneal fluid. Alternative, less often used methods for visualization of an aneurysm include MRI and angiography, and then there is in ruptures if the mechanical stress exceeds the local wall strength. Consequently, peak wall stress and peak wall rupture risk have been found to be more reliable parameters, and diameter to assess AAA rupture risk. Medical software allows computing these rupture risk indices from standard clinical CT data and provides a patient-specific AAA rupture risk diagnosis. This type of biomechanical approach has been shown to accurately predict the location of AAA rupture. An aortic aneurysm is seen on CT with a small area of remaining blood flow. Ultrasound showing a previously repaired AAA that is leaking with flow around the graft. Classification. Abdominal aortic aneurysms are commonly divided according to their size and symptomatology, and their ISM is usually defined as an outer aortic diameter over 3 cm, or more than 50% of normal diameter. If the outer diameter exceeds 5 cm in Arizona is considered to be large. A ruptured AAA is a clinical diagnosis involving the presence of the triad of abdominal pain, shock and pulsatile abdominal mass. If these conditions are present, indicating AAA rupture, no further clinical investigations are needed before surgery. Smoking cessation treatment of hypertension. The U.S. Preventive Services Task Force recommends a single screening ultrasound for abdominal aortic aneurysm in males aged 65 to 75 years who have a history of smoking. There is an estimated number needed to screen of approximately 850 people. It is unclear if screening is useful in women aged 65 to 75 who have smoked, and they recommend against screening in women who have never smoked. Repeat ultrasounds that should be carried out in those who have an aortic size greater than 30 cm. In those whose aorta is between 3.0 and 3.9 cm, this should be every 3 years if between 4.0 and 4 cm every 2 years, and if between 4.5 and 5 cm every year. In the United Kingdom, one-time screening is recommended in all males over 65 years of age. Australia has no guideline on screening. The treatment options for asymptomatic triple-layer conservative management surveillance with a view to eventual repair and immediate repair. Two modes of repair are available for in AAA opening: RZM repair and endovascular aneurysm repair, and intervention is often recommended if aneurysm grows more than 1 cm per year or it is bigger than 5 cm. Repair is also indicated for symptomatic and tourism's conservative management is indicated in people where repair carries a higher risk of mortality and in patients where repair is unlikely to improve life expectancy. The mainstay of the conservative treatment is smoking cessation. Surveillance is indicated in small asymptomatic aneurysms where the risk of repair exceeds the risk of rupture. As N grows in diameter, the risk of rupture increases. Surveillance until a aneurysm has reached a diameter of 5 cm has not been shown to have a higher risk as compared to early intervention. Medication. No medical therapy has been found to be effective at decreasing the growth rate or rupture rate of asymptomatic AAAs. Blood pressure and lipids should, however, be treated for usual surgery. The thresholds for repair vary slightly from individual to individual, depending on the balance of risks and benefits when considering repair versus ongoing surveillance. The size of an individual's native aorta may influence this, along with the presence of comorbidities that increase operative risk or decrease life expectancy. Evidence, however, does not support repair if the size is between 4 cm and 5 cm. Open repairs indicated in young patients as an elective procedure, or in growing or large, symptomatic or ruptured aneurysms. Aorta must be clamped off during the repair, denying blood to the abdominal organs and sections of the spinal cord. This can cause a range of complications. It is essential to make the critical part of the operation fast, so the incision is typically made large enough to facilitate the fastest repair. Recovery after open AAA surgery takes significant time. The minimums are a few days in intensive care, a week total in the hospital, and a few months before full recovery. Endovascular repair first became practical in the 1990s, and although it is now an established alternative to open repair, its role is yet to be clearly defined. It is generally indicated in older high-risk patients or patients unfit for open repair. However, endovascular repair is feasible for only a proportion of AAAs depending on the morphology of the aneurysm. The main advantages over open repair are that there is less perioperative mortality, less time in intensive care, less time in hospital overall, an earlier return to normal activity. Disadvantages of endovascular repair include a requirement for more frequent ongoing hospital reviews and a higher chance of further procedures being required. According to the latest studies, the VI or procedure does not offer any benefit for overall survival or health-related quality of life compared to open surgery. Although aneurysm-related mortality is lower, in patients unfit, rope and repair evolved or plus conservative management was associated with no benefit, more complications, subsequent procedures, and higher costs compared to conservative management alone. Endovascular treatments for perigonous demotic aneurysms after aortic iliac reconstruction is also a possibility. Of 2017 Cochrane review found tentative evidence of no difference in outcomes between endovascular and open repair of rupture AAA in the first month rupture. In those with aortic rupture, of treatment is immediate surgical repair. There appears to be benefits to allowing permissive hypotension and limiting the use of intravenous fluids during transport to the operating room. Although the current standard of determining rupture risk is based on maximum diameter, it is known that smaller AAAs that fall below this threshold may also rupture, and larger AAAs may remain stable. In one report, it was shown that 10–24% of ruptures more less than 5 cm in diameter. It has also been reported that of 473 non-repaired examined from autopsy reports, there were 118 cases of rupture, 13% of which were less than 5 cm in diameter. This study also shows that 60% of the AAAs greater than 5 cm never experienced rupture. For Bacall later deduced from the findings of Darling et al. That if the maximum diameter criterion were followed for the 473 subjects, only 7% of cases would have succumbed to rupture prior to surgical intervention, as the diameter was less than 5 cm, with 25% of cases possibly undergoing unnecessary surgery since these AAAs may never have ruptured. Alternative methods of rupture assessment have been recently reported. The majority of these approaches involve the numerical analysis of AAAs using the common engineering technique of the finite element method to determine the wall stress distributions. Recent reports have shown that these stress distributions have been shown to correlate to the overall geometry of rather than solely to the maximum diameter. It is also known that wall stress alone does not completely govern failures. Will usually rupture when the wall stress exceeds the wall strength. In light of this, rupture assessment may be more accurate if both the patient-specific wall stress is coupled together with patient-specific wall strength. Non-invasive method of determining patient-dependent wall strength was recently reported, with more traditional approaches to strength determination via tensile testing performed by other researchers in the field. Some of them more recently proposed triple A rupture. Risk assessment methods include triple A wall stress, triple A expansion rate, degree of asymmetry, presence of intraluminal thrombus, or rupture potential index of finite element analysis, rupture index, biomechanical factors coupled with computer analysis, growth of AILT, geometrical parameters of, and also a method of determining growth and rupture based on mathematical models. The post-operative mortality for an already ruptured has slowly decreased over several decades, but remains higher than 40%. However, if the triple A is surgically repaired before rupture, the post-operative mortality rate is substantially lower, approximately 16%. The occurrence of varies by ethnicity. In the United Kingdom, the rate of Caucasian men older than 65 years is about 47%, while in Asian men, it is 0.45%. It is also less common in individuals of African and Hispanic heritage. They occur 4 times more often in men than women. There are at least 13,000 deaths yearly in the US, secondary to triple A rupture. The peak number of new cases per year among males is around 70 years of age. The percentage of males affected over 60 years is to 6%. The frequency is much higher in smokers and non-smokers, and the risk decreases slowly after smoking cessation. In the US, the incidence of to 4% in the adult population. Rupture of the triple A occurs in 1–3% of men aged 65 or more. The mortality is 70–95%. The first historical records about from ancient Rome in the 2nd century add, when Greek servs Nancy Ellis tried to treat the triple A with proximal and distal ligature central incision and removal of thrombotic material from the aneurysm. However, attempts to treat surgically were unsuccessful until 1923. In that year, Rudolf Madies performed the first successful aortic ligation on a human. Other methods that were successful in treating the included wrapping the aorta with polyethylene cellophane, which induced fibrosis and restricted the growth of the aneurysm. Albert Einstein was operated on by Rudolf Nissen with the use of this technique in 1949, and survived 5 years after the operation, though he eventually died when the Anderson ruptured. Endovascular aneurysm repair was first performed in the late 1980s and has been widely adopted in the subsequent decades. Endovascular repair was first used for treating a ruptured aneurysm in Nottingham in 1994. Former presidential candidate Bob Dole had an abdominal aortic aneurysm in 2001 and was treated surgically by vascular surgeon candidate Al Real. The operation was successful. In 1993, country music singer Conway Twitty died from triple A, and actor George C. Scott also died of an abdominal aneurysm. In 2001, former presidential candidate Bob Dole underwent surgery for an abdominal aortic aneurysm, in which a team of surgeons led by Dr. Kenneth Averill inserted a stent graft. Associated Press actor Robert Jacks, who played Leatherface in Texas Chainsaw Massacre, The Next Generation, died from an abdominal aneurysm on August 8, 2001. Just 1 day shy of his 42nd birthday. His father also died from the same cause when Robert was a child. Musician Conway Twitty died in June 1993 from an abdominal aortic aneurysm, aged 59. 2 months before the release of what would be his final studio album, Final Touches, theoretical physicist Albert Einstein had internal bleeding from a ruptured abdominal aortic aneurysm which had previously been surgically reinforced. He declined surgery, saying, "I want it to go when I want. It is tasteless to prolong life artificially. I have done my share. It is time to go. I will do it elegantly." He died the following morning on April 18, 1955 at 76 years old. Risk assessment. There have been many calls for alternative approaches to rupture risk assessment over the past number of years, with many believing that a biomechanics-based approach may be more suitable than the current diameter approach. Numerical modeling is a valuable tool to researchers, allowing approximate wall stresses to be calculated, thus revealing the rupture potential of a particular aneurysm. Experimental models are required to validate these numerical results and to provide a further insight into the biomechanical behavior of the triple A in vivo. AAAs exhibit a varying range of material strengths from the localized weak hypoxic regions to much stronger regions and areas of calcifications. Experimental models can now be manufactured using a novel technique involving the injection molding lost wax manufacturing process to create patient-specific anatomically correct replicants. Work has also focused on developing more realistic material analogs to those in vivo, and recently a novel range of silicone rubber was created, allowing the varying material properties of the AAA to be more accurately represented. These rubber models can also be used in a variety of experimental testing, from stress analysis using the photoelastic method to determining whether the locations of rupture experimentally correlate with those predicted numerically. New endovascular devices are being developed that are able to treat more complex and tortuous anatomies. Prevention and treatment. An animal study showed that removing a single protein prevents early damage in blood vessels from triggering a later stage complications. By eliminating the gene for a signaling protein called cyclorfunland from a strain of mice, researchers were able to provide complete protection against abdominal aortic aneurysm. Other recent research identified GRANTS to be a potential target in the treatment of abdominal aortic aneurysms. Elimination of this enzyme in mice models both slowed the progression of PRISMs and improved survival. Thanks for watching this video. Subscribe to our YouTube channel for more videos. Let us know if you have any question and comment below. If you enjoy this video, please like the video and also subscribe to our channel. Thank you for watching.